Hello, in this video I want to touch on the medical management of prostate cancer and why one lab result cannot always provide a clear disease outcome. Before we begin, I want to show where the prostate is located. It's found here, below the bladder and in front of the rectum. 11% of men at some point in their life, usually between the ages of 55 and 75, will develop prostate cancer. When the cancer is discovered, it will either be localized, meaning that the cancer is only within the prostate, regional, meaning that the cancer has spread outside the prostate but is within the pelvis, or distant, meaning that the cancer has spread as far as the patient's chest. If the cancer is distant, even with treatment, only 33% of patients live longer than 5 years. For this reason, proceeding with treatment is a clear choice for many patients with distant prostate cancer. Now, for patients with localized regional cancer, patients with treatment have a 5-year survival of 99.9%, meaning around 0.1% die from prostate cancer. For patients who do not seek treatment, the 5-year survival rate is estimated to be between 80 to 87%. The remaining 13 to 20% develop distant prostate cancer. Before continuing, I want to explain how prostate cancer is treated. Treatment involves surgically removing the prostate, called a prostatectomy, chemotherapy, radiation therapy, and/or hormone therapy. These treatments are invasive and come with side effects such as infections and difficulty controlling urine. Now that we have a brief idea of the treatment, some patients who fall into this group will look at the 80 to 87% chance of survival and consider taking their chances without treatment. One reason is that localized or regional prostate cancer does not cause symptoms other than difficulty urinating. Sometimes, autopsies find undiscovered prostate cancers in patients who had died of a separate disease. This goes to show how people can live their lives with prostate cancer and never have it affect them. Over the years, doctors have become better at predicting which localized or regional prostate cancers will metastasize, or in other words, spread. That way, treatments are provided to patients who will more likely benefit from them. I recently came across a 2007 research article from the Journal of the National Cancer Institute. The researchers were investigating ways to identify potentially deadlier prostate cancers. Unfortunately, their experiment was unsuccessful in isolating at-risk individuals, but the article has interesting information. In order to understand what the article was investigating, I need to explain prostate-specific antigen, or PSA for short. PSA is a chemical or molecule that comes from the prostate. Normally, a very small amount is found in the blood. Increased levels of PSA can be due to the following prostate diseases: prostate infections, prostate physical traumas, prostate growth over time, and last, prostate cancers. That covers PSA. The researchers wanted to investigate if someone has prostate cancer, then can the amount or change in their PSA levels be used to predict the outcome of their prostate cancer. Their hypothesis, or guess, was that a higher starting and/or rapidly rising PSA level means an increased chance of a local or regional prostate cancer becoming deadly. The researchers used the PSA levels of 267 patients with untreated localized or regional prostate cancer that were collected over a period of 2 years. The average number of collections of PSA levels per person was 4 to 5. Then, after an average of 6.5 years, the researchers compared patients' starting PSAs and their PSA changes over time with the outcome of their prostate cancers. This was the outcome. Among them, the researchers were interested in those who had died from prostate cancer because they wanted to see how well PSA levels do at identifying the individuals who died from their prostate cancers. And as I mentioned earlier in the video, the experiments couldn't identify at-risk individuals. In other words, PSA levels could not adequately identify at-risk individuals. I do want to mention that deadly prostate cancer was associated with both the PSA starting point and an increase in PSA over time. However, though there is an association, the association is a weak one. The sensitivity was 70% and the specificity was 60%. If you're unfamiliar with the statistical terms sensitivity, and specificity, then I recommend watching one of my other videos which covers the topics. To help give the idea, there was one patient who lived with a starting PSA value of 1000 and an increase of 10 nanograms each year, whereas another patient had unfortunately died with a starting PSA value of only 4 and a decrease of 1 nanogram per year. What can we learn? That around 80 to 87% of men can live the rest of their lives without being affected by untreated prostate cancers, and that one lab result does not provide a whole picture. I hope this helps show why a doctor may be pursuing treatment options despite a reassuring lab result, as well as why a doctor may advise against treatments despite a concerning lab result. In general, if you have any questions regarding a treatment plan, it is best to speak to your doctor. Let them know your priorities, such as maximizing survival rate or minimizing side effects. That way, the most appropriate course of action can be decided upon. This finishes the video. Thank you for expanding your medical knowledge. Comment below on which topics you are interested in learning more about. Also, leave any feedback on how these videos can better serve you.